to Future Proof PT, where we explore innovative approaches that are shaping the future of physical therapy. I'm Dana Strauss, and in today's episode, we're bringing you an inspiring conversation from early career physical therapist Cody Lee, who's already making waves. You're about to hear how a young clinician is revolutionizing patient care by building a strong professional network, implementing effective mentorship systems, and creating a practice model that truly serves both patients and providers. Cody shares his unique perspective on servant leadership and how it's transforming his approach to patient care. In this episode, you'll discover practical strategies for building and leveraging professional communities to enhance patient outcomes, implementing servant leadership principles in your daily practice, navigating the challenges of early career practice while maintaining clinical excellence, creating sustainable models for long-term success in physical therapy. So whether you're a seasoned professional or just starting your PT journey, this conversation offers valuable insights into the future of our profession. Get ready for an engaging discussion that will leave you inspired and equipped with actionable ideas to elevate your practice. Let's dive into episode 10. Hi, everybody. Welcome to episode 10 of the Future Proof PT podcast. Today, Alex and I are joined by our second guest. His name is Cody Lee. He is a physical therapist, we would say earlier career, who you wouldn't know that he's early career by how much he's accomplished and how much really smart thinking he does. And we brought Cody on to talk a little bit about some of the influences on his earlier career and some of his observations about the healthcare industry, on how he is incorporating some of the concepts of value-based care into his own specific physical therapy practice. And so we are going to hand the floor a bit over to Cody to tell us a little bit more about sort of what he's doing in his day job and some of the work he is doing to try to advance value-based care locally. And then, well, talk a bit about his work in the Alabama Physical Therapy Association. So Cody, if you want to give us a little background, what are you doing? What's exciting you lately? And we'll take it from there.
Yeah, sounds good. First, thanks for just having me on. I've really enjoyed listening to the podcast. It's been very impactful early on for me already, and really appreciate the work you are doing, and everything you are putting out it's really, really helpful for me as an early career clinician for sure. So a little background on me: graduated from PT school, like you said. I'm early career, August 2023, from the University of St. Augustine. So I did their flex program. So I was able to be in the clinic while I was in school. I worked full time as a tech and then as a access specialist or in our front office. So I got to see kind of the healthcare system from a different lens than just as a treating clinician, which was super helpful, and kind of seeing the impact different roles have within our system and within our clinic specifically. But currently I'm at a hospital-based outpatient clinic with Southeast Health. So we have PT, OT, speech. We have a neurobalance center as well. But clinically, I focus a little more on, we have general orthopedics, and then have a big population of chronic pain patients. So that's kind of where my focus is, and doing that day to day. And then, like you said, I've started working more with the Alabama APTA, and now I'm the co-chair of our membership committee for our association.
Fantastic. I think maybe first, you have shared a couple of stories about working with patients and taking lessons, if you want to call them, from our episodes or from things that we've written about how you've kind of applied some just basic concepts about value-based care to general practice. And that is as simple as coordinating with a physician to share something that affects their longitudinal care potentially. Do you mind telling us a little bit about one of those anonymous, of course, patient stories?
Yeah, definitely. So like I said, y'all have already made an impact on me from that perspective. And I think it was a few episodes ago when you talked about kind of care coordination and that sort of thing in general. And so that was something I've been thinking more about, and had a patient recently who came in mid 60s, seeing her for low back pain. As we're doing kind of the evaluation, the subjective, get to understand a little bit about, she kind of always called herself as healthy, like she didn't take medications and that sort of thing. Didn't have a primary care provider, mainly just uses urgent care when she's sick or needs some sort of care. So as a part of my normal intake process when I'm doing my evaluations, I always check vitals. So screened blood pressure, and it was, I think, systolic was in the 160s that day. And so we had a brief discussion about it. She never mentioned anything about having high blood pressure. She wasn't really aware of it. So kind of initially broached the subject of, well, have you thought about maybe having a primary care provider who could, manage this for you? One thing to note, she had a little bit higher anxiety, so I didn't want to take the one, data point and say, okay, you've got high blood pressure. So had her track it over a few days in between our appointments, and then when she came back, we're able to see it is consistently saying high, and had a further discussion about getting connected with a primary care provider. And thankfully, we have some relationships with primary care providers in our area. So was able to just text one that we have a good relationship with, give her a brief rundown. She was happy to see the patient. Eventually was able to get her in within the next week or two, I think, and get her established with her. So she's under her care now, and then managing blood pressure with medication. And then we continue to see her for her back pain through her plan of care. So it was a good interaction, and y'all are definitely impactful and kind of teaching that lesson, making me think about it more, and then trying to apply it in daily practice. And then the patient was grateful for it as well. So it was a good experience.
I think it's such a wonderful example of you fitting directly into the healthcare model, you as a professional. And so we tend to judge different clinical and healthcare modalities as a standalone solutions, but they're really interconnected. So you being a musculoskeletal specialist understood that her comorbidity directly fits into her musculoskeletal complaint, but needs to be addressed by the proper fitting specialist, right? So I guess a generalist. So you use your network to apply the right tool at the right time for the right patient so that she can get better. So you can actually manage her back pain more effectively. The physician can manage her hypertension more effectively. And I think that's an ideal model, right? Where you can apply the right fit for the right customer or the right fit for the right patient. So I'll ask you a question. I think based on what you described, right? So Adam Grant has an interesting point that any professional is simultaneously a coach, a judge, and a referee, right? So taking care of patients, you are a coach because you are helping them. You're judging them because you have to evaluate their shortcomings. But you're also a referee where you delegate the right structures based on that event. For someone who doesn't have as good of a network as you, what suggestions would you have? Like, how would a clinician go out and look for these services or look for these referral network? And how does one create a referral network just based on your experience?
Yeah, I mean, I think it just begins with relationships and having conversations and getting to know the providers in your area. This particular relationship kind of developed over time, actually, from our clinic manager. Before he was our clinic manager, he was a treating PT, and this particular physician worked within our hospital system at our residence clinic. And so he went to meet with those two primary care providers that were kind of running that clinic to get a better understanding of like how PT could be involved with them and explain a little bit more about what we're doing and that sort of thing. So he just reached out to them, asked for a meeting, and they set one up briefly at lunch, just begin a conversation there and begin a relationship. And then just that kind of over time, you create value for them. You continue to, make deposits rather than withdrawals, and then just build the relationship. So I think it's more of, just have to reach out to those providers. I think there are some that probably are going to be more open than others, which is just life in general, I think. But yeah, I think that's the biggest part to me, is just beginning the conversation and reaching out and then developing the relationships over time.
And that reciprocity, right? So you're right, spot on. That the deposits and withdrawals, like once you are part of this network, it really becomes you level the playing field. So that the same physician will then respect you and your set of
Mhm.
skills to provide care when it's necessary. And in a way, if you go into that value-based model, like that, this is ideal because you're able to cut away any of these low-value, high-price services. You're able to establish a direct network of treatment price of musculoskeletal care so high that once you get these direct referral networks, you are able to do away with a lot of the low value care. So let me ask you this question. What got you into physical therapy in the first place? What was your journey to this field?
Yeah, so it wasn't like I was injured or anything like that. I feel like that's a pretty common, you experience it yourself and then you want to be a part of it. I actually, when I was first in college, I was doing CrossFit, just interested in that. I became aware of Kelly Starrett, and he was big in that space, a physical therapist out in California, and started following his work, reading his books, and that sort of thing. And it kind of initially got me interested in it. Then went to undergrad for exercise science, and it wasn't really until I became a tech after school that I was like, oh, this is what PT actually is. But just in general, I was interested in strength and conditioning principles, exercise, human anatomy, physiology, and that sort of thing in general. And that's kind of how I got into it, and thankfully I ended up liking it.
And now 2 years into it, how do you see your decision after like the entire journey now that you're already on the road?
Yeah, yeah. I mean, I'm glad I'm in the profession. I'm glad I'm doing it. I think thinking back, it's one of those things I probably should have just like shadowed and observed just more careers and professions in general, just to get a better idea of like what's out there, just to be able to make a better decision. But I think ultimately it turned out well for me, and I really enjoy the opportunity to serve patients and serve people on a daily basis in the capacity that I am, and really kind of get to intertwine the anatomy, the physiology, and all of those things on a regular basis.
So yeah, I know you're directly involved with Alabama Physical Therapy Association. How and what do you think of just in general APTA, but even local physical therapy associations can do to both advocate for the profession, but also how can they better support clinicians through this early journey and then mid journey, right? What can these associations do to both advocate for our greater industry, but also for us in the field?
Yeah, so last year I got more involved whenever we had a bigger push for direct access, and that's when I really got to see kind of what goes on within the chapter association and how much work it takes to kind of get things done. I think one thing we do poorly is communicating what actually gets done and how much work there actually is. A lot of times I feel like the clinicians I work with don't understand, what the APTA does as a whole or what our state chapter does as a whole. And that's a little bit on clinicians. I think we have to be better engaged, but also as the organization of the APTA and the state chapters, we have to do a better job communicating that message and getting that out clearly in different mediums, rather than maybe just an email blast every now and then. So I think a big part is communicating what you're actually doing for the professions in your state and across the nation, which now that I'm more involved, I get to see that, close up. And that was one reason I wanted to get more involved is to be a part of what's actually going on. As far as continuing to advocate for the profession, I think continuing to work on payment reforms is a big one. I feel like we've talked about for a long time, but also understanding value-based care, understanding alternative payment models, educating PTs on that outside of just fee for service. I think pushing forward like the work y'all are doing as far as talking about primary care integration, explaining that. I think y'all have done an excellent job of demonstrating and communicating how valuable that is, and kind of going forward with value-based care in general. I guess that's kind of a place to start.
That's right on. APTA and local physical therapy association the chapters continue to communicate on AM radio, and the rest of the community has moved on to internet, right? So
Yes.
I
I
think
didn't
that
even know that.
isn't it like you find that they continue to blast their message through these low auditory medium, like, and so
Mhm.
they think that just because they're on AM radio, people will listen. But our community has moved on and digitized. And if you look, Reddit has a physical therapy chapter with 78,000 members. So these are young clinicians that are there voicing their opinions, voicing their concerns, and it's incredibly active chapter. So just digging through it and looking into some of the primary concerns for our profession. And this is what we're going to talk about AI a little bit, but this is where the AI is really good about digging through like 10,000 posts and finding out the most common themes. And the most common theme is that unsustainable tuition growth, like that PTs are really concerned about the fact that we're graduating with just huge debt, right? That there's a financial literacy gap. Like we just don't know how to manage both the in-clinic expenses and out-of-clinic expenses. We have a concern about declining reimbursement rate. We're just not seeing return on the investment once we're there. And then the other important theme therein is productivity pressure. Clinicians are like graduate school, and then all of a sudden they have these productivity matrix that they weren't comfortable with. So let's start with the last one. With the productivity pressure, working for a system, do you feel like you were well prepared for some of the benchmarks of productivity and expectations? Because you did have extensive experience in it before you started working as a full-time clinician.
Yeah, I think for me, I'm in kind of a unique position with the clinic that I'm in, as we're not as high volume as you might see with some private practices, like in my clinical rotations, where we would see anywhere from 12 to 16, sometimes a little more than that. Thankfully for us, productivity, it's something we look at, but it's not harped on all the time to the point of like, if you don't hit this metric, something's bad is going to go on. It's important, of course, but I think for me, I'm lucky in that we focus more on kind of the quality. We know certain measures we have to hit, but really just providing the care that's needed for the patient in front of you. I think that would be a different story if I was in maybe a private practice where it is a little higher volume, managing the productivity pressure. But I think that's something you touched on recently, Alex, when you mentioned, are you unhappy with your job or in your job? I think you're making the difference, the clarification there. Is it the profession or is it just the particular role or clinic you're in? And so I think that's a big one as far as when you are choosing a role and choosing a clinic, like it's on us too to kind of do our due diligence to know, is this a good fit culturally for me? Is this the type of volume I want to see? And obviously there's the financial concerns as well. And depending on where you live, maybe there are fewer options, but I think that's something to think about in general.
Yeah, I think earlier in my career, I had a colleague who was a dual certified. He was a PT and a chiro. So his model, he would see 45 to 60 patients a day. And he made it work in a way because he primarily was doing the 5-minute consult, and then the ancillary stuff, the support staff provided all the triage. So in a way, you can obviously make an argument whether how advantageous it was for patients' well-being, but clinically it was a model that worked. Versus, I've also had clinicians that refused to see any more than 8 patients. They needed that 1 hour of direct one-on-one care and an 8-hour day. But then, based on your experience, and speaking about the value-based care, right? So, in order to provide high-value care, there is that patient-specific matrix where you have to provide the right care at the right time, but you also have to be able to leverage technological resources and ancillary resources to sustain this value. Otherwise, I think that when you are seeing a patient for an hour, you really have to work hard to justify that 60 minutes of value time. So how would you see like both models, seeing 60 patients or seeing only 8 patients a day?
I mean, I think there could be a combination of the two or a hybrid, not necessarily one extreme or the other. We tend to be on the more one-on-one side, and I think the more I've kind of come to learn different perspectives, different models, being able to appreciate that one-on-one isn't necessarily right for every patient. They don't necessarily want one-on-one for every single treatment. There are some people that are going to want that attention, some that aren't. So I think appreciating more of like I could do a shorter treatment or I could have multiple patients at one time. I think being on LinkedIn, I've been able to see a lot more perspectives from different PTs and the PT Breakfast Club. I think I've been able to see some different perspectives there and what they talk about and kind of the group exercise concept. And I don't think it has to be one-on-one. I think it really depends on the patient in front of you, what you feel like they need. If it's truly they need one-on-one care, then maybe they get that. But I think for me, I like a little bit of not necessarily 8 a day, but a little more than that, where you have, a couple at the time and are able to kind of bounce between and still give, high quality care. At my first clinical rotation, which is about 30 minutes from where I am now, I think they did a phenomenal job so they would have 12 to 16 per day, one-on-one evals, so never overlap from an eval perspective. But each treatment was normally two at the time and kind of split 30 minutes and 30 minutes, kind of going back and forth. And it's a smaller clinic, so they were able to manage that. But I would say it's probably the highest quality care I've seen. And I can't speak highly enough about that particular clinic and the therapist there. But just being able to give, the 100% presence to the patient that's in front of you, exactly what they need, and then you can bounce over to the other person when it's needed. So I think there's definitely a balance.
I think that it's so important to appreciate a couple of things from what you said. The first is the same patient on visit 1 has a very different value allocation than on visit 6, right? So each visit carries its own unique ability to allocate a differentiated value. So the initial visit is all about assessing and understanding a patient and listening to the patient. But once you have an established patient who's going through their recovery journey, same individual may not need the same amount of individualized attention as long as the plan of care is structured with best practices and following evidence-based or evidence-guided clinical allocation. So that like the recovery journey as clinicians, we need to be able to be discriminant about each visit carries its own opportunity, and each visit should not be a repetition of a previous visit. The second part that's really important is you said that clinic that was able to provide high value care while still managing multiple patients. We tend to see our service as the important ingredient, but there is a lot of contextual factors that play into the individual's experience, right? And the setting is important. So if the clinic was small, but was designed in a way where the patient was able to have a fit, you no longer need to expend your own energy if the patient knows what to do and how to do it. Same goes for support personnel. I think every medical professional in the world that is unable to practice themselves, they have support personnel, right? You go to see your dentist, there's a hygienist, there's a dental assistant, there's a receptionist. In a physician's office, there is a nurse, there is a medical assistant, there is, again, a receptionist, a billing personnel. So in a physical therapy setting, we're indoctrinated to feel like we have to provide comprehensive care from A to Z. I think if we're going to continue on this value-based journey, we really need to be specific about what is good from our perspective, but how can we leverage technology? How can we leverage contextual factors? How can we leverage support personnel to provide this high value care while still maintaining high moral ethics, high conduct, where the patient is receiving maximized support from us as clinicians, right? But
Right.
I want you to talk a little bit about how you leverage technology in your clinic and how you trained a model to help support this complex patient journey.
Yeah. So I absolutely love the functionality of AI and LLMs and have kind of I dive deep into them, and they've been fun to use lately. So I had a recent patient that I've been seeing over the past few months, probably about 6 months. We switched over to a cash pay model at a certain point. So he had an ACL reconstruction and meniscus repair. And so for me in my clinical rotations, I hadn't seen a patient from start to finish almost, or this high level of a patient who young athlete, mid 20s, wants to get back to playing soccer. He plays recreationally, but level 1 sports is his goal. So really this was going to be my first time kind of managing ACL reconstruction and a meniscus, but ACL in general. So at first I just started looking at a lot of research, listening to every single podcast I could find on the topic. And so just doing a deep dive there. And then what I've been using is Claude specifically, which is a LLM. And within it, you can create projects. And so within that project, you can then upload kind of context specific source material to it rather than just what it's trained on. And so I just created an ACL project, and then I took basically every article that I found that was a clinical practice guideline, multiple protocols. So from like Ohio State University, University of Delaware, the Moon Protocol, any like big name protocol, Andrew Sports Medicine, I put them all in there. I put all the research articles in there, and then I was able to essentially query that specific information, ask it questions, develop more criteria based approach rather than just a timeline based approach, which you can also put in blogs and different articles, transcripts, anything that's text pretty much. So I used E3 Rehab as a fantastic ACL blog and put out a ton of information on it. So I followed a lot of theirs and put their blogs in there. So essentially I was able to use that as kind of a clinical support or clinical mentor almost for this particular population and this particular patient. So I could take the objective data I was getting from my patient. So thinking about swelling measurements, range of motion, where he was in his particular protocol, the timeline, his limb symmetry index, the torque measurements. So all of the objective measurements I could put in there, and I could know where I should be based on these protocols, based on the articles. And it gave me a sense of confidence to be able to go specifically to the research and the evidence and find exactly the answer I'm looking for, or it could guide me in a different direction. I really enjoyed kind of playing around with like, this is what we did last treatment, exercise wise, progression wise. This was the response, swelling, pain or not, kind of how he felt over the course of days afterwards, and even play around with scenarios of like, how could I progress this particular exercise, or what are some things I should be thinking about. Or there were a couple times when he started to have some pain intermittently around the knee. And so I was a little concerned, like, oh gosh, am I doing something wrong? Because like everything we were doing was for the first time I had done it with this patient. And so I was able to ask, and it gave me a whole list of different things of like, it could be patellofemoral pain syndrome or this tendon or just a bunch of different things to be looking out for, and essentially was able to kind of guide me in the process. We don't have any mechanism of injury here. We don't have reactive swelling. So it's likely he's not injured. He didn't hurt himself any further. It's just a part of the process. This is normal. So that was huge just through that whole process to be able to kind of query that information. So if you're not thinking about using AI or if you haven't tried it, I would encourage you to try it. It's very useful, especially from a clinical support standpoint, like thinking, being able to play out scenarios and different things like that. And it never made the decision for me. I never said, create this plan and I'm going to follow it, or, that sort of thing. I just used it as a way to enhance my clinical reasoning, essentially.
Yeah, I think technologists would call it you are a human in the middle. So you became a professional in the middle. And I think for that specific patient, and at that time, you were probably in the top 0.001% of all physical therapists in the country, because you had the most up-to-date, absolutely best information to guide this individual across. So you liberated yourself from the burden of carrying all this information in your head, right? But you were able to leverage this data and this information to provide that the best practices for that individual recovering from surgery. And I think that this is where technology is an absolute must. So what you have done on your own is pretty much what, in a way, you can package it and start to commercialize it. Then most clinicians will only benefit from this level of technology because it doesn't take away from your agency. It actually enhances it, right? It adds to your ability. So that's wonderful. So I will now politely shut up and let Dana speak because
No,
I
no,
will.
I just had a follow-up question. If you shared any of this with the surgeon, I think it could be potentially really interesting for a surgeon to hear about how a therapist is using AI in a unique way, or if it's something that you shy away from because it's can be difficult to talk about AI.
Yeah, I didn't talk about it directly with this particular surgeon, although he is very open with communication, and that's wonderful for patient coordination and being able to talk about him in general. Because when this patient did start to have a little pain, I did, mention it to him and I was like, hey, what do you think's going on at this point? And so we were able to have a dialogue. But I never mentioned it specifically. Honestly, it's not something I thought about doing, but could be useful in the future. And I will say a caveat to, that whole story was eventually we did get to a point where we were getting into much higher level, more return to sport, different drills and things of not knowing how to progress. And although, I was able to query that information, it was able to give me useful info. At some point, I did want to be able to speak to expert, a human expert. So at that point, I actually reached out to Eric Mira and was able to have, like a 15-minute call with him. um, that was a great conversation to be able to kind of know, the current phase we're in, we're stalling a bit, and he, reassured me that that's normal and to be expected, and just kind of a part of the process. And that's something they talk about with all their athletes is that you're going to get to a point where your quad is probably going to stall. So that made me feel better there. So I will say the value in a human expert is still there. And also, I would encourage if I think I wrote about this recently, was when I was at Alabama. I was a student manager for the softball team, and the coach there always said it's a 3-letter word, ask. And so I just asked, I reached out to him, and he was willing to get on the phone. So if there's someone you're considering to asking and want to pick their brain or that sort of thing, first create value for them if you can, and then just ask, because the worst that they could say is no.
Yeah, so it's amazing that you actually referenced Eric Muir. So if in the PT world, if you ask me to name 5 smartest physios, Eric would be definitely in the top 3.
Uh-huh.
Like an absolutely brilliant dude. And I think you're right on. I think that we get siloed in our practice, and I think how many clinicians, especially after maybe 5 or 7 years in practice, just get indoctrinated into that system and they get siloed. And that siloed effect is that we don't use the 3-letter word. We don't ask. And there is, I think, a heuristic, which is a curse of knowledge, which unfortunately, the farther along you go, the more experienced you become, the more cursed you become as well. Like it's the hedgehog and the fox, right? The hedgehog knows many things and the fox knows one thing. Or you become this level 1 expert, and you become so siloed that you don't ask, and that expertise actually becomes your curse because you no longer are capable or willing to ask or admit your shortcomings. And that's like I was thinking about this episode yesterday and reflecting on my 22-year journey, and I just realized now how stupid I am currently because of just the abundance of information that I either don't know or I'm oblivious to, because I just get this arrogance, right? Like I know, but it's being humble and being able to ask and leverage your network. So, and we spoke about networks from a standpoint of value-based commercial healthcare networks. But there is that internal network that you're building too, which is a network of experts within the PT world. And I think again, Cody, you are practicing on top of your license because you have this professional network and you're willing to ask, compared to someone else who will not. I guess then I will throw it back to you. How would you, like you asked, what medium and what's the best way to build this professional internal network for a young clinician?
Well, for him in particular, at first I was consuming a lot of his blogs related to ACL rehab for this particular patient as well. And he just had a contact form on there. And I just threw in a message to him. And basically, I just try to keep it concise and brief and respect his time, because I know he works with a lot of high level folks and is a very busy person. So I think a lot of times we can go wrong with, asking for something without, like I said earlier, making a deposit. You're just kind of just trying to make a withdrawal. So like you have to create value for the other person, and I think respect, their time and their expertise. But one, starting to identify who are those people that you want to get around or want to learn from. How can you start to engage with them in a professional setting, whether that's locally or if it's on LinkedIn even, or something along those lines, just engaging, providing value. If we're thinking about LinkedIn specifically, like, and someone makes a post and you comment like, thanks for sharing, that's nice, but like, can you provide value within the comment of like adding to the conversation or discussion? And I think that could be used across any medium really, is just how can you create value for the person across from you or who you're trying to engage with? Because like we said earlier, reciprocity, it's likely that they will want to reciprocate and create value for you as well.
I just gonna say a couple of themes that have come up for me listening to this, and it's been great to actually hear your dialogue and reflect on some of the themes. First, the the concept of patient first care, where everything that you're describing is when it comes to connecting with others so that you can learn from them and apply it to patients, or using AI to improve your ability to care and deliver the right treatment for patients, or it's developing those relationships outside of just your clinic. All of those things, although we try to complicate what value-based care is, all of those things are patient first, patient-centered care. And that's just a synonym for value-based care, right? And the other thing that I've been reflecting on and listening to this is, communication and connection and relationship building. AI cannot replace those. And that's something, a skill set that therapists have that in in our healthcare industry, healthcare professional space, it's essentially therapists and behavioral health providers are the ones that are really experts in that. And we have to embrace, and I love that we're talking about that kind of value, that how hard it is to develop that skill and flex it and realize how important it is so valuable in an evolving landscape where engaging and connecting and building relationships without overcomplicating a lot of we want to overcomplicate sometimes, right? Without overcomplicating, we can end up serving in value-based arrangements very simply without really changing much if this is the way we're practicing anyway, right? So I hear a lot from you. You're doing what you see organically is finding ways to best serve patients. And a lot of that boils down to continuous learning, communicating, and adding value so that that shared value, that reciprocity can help everyone grow and helps patients improve. And I hear too from you that you're focused a lot on servant leadership. And I'll leave it there because I'd love to hear you talk a little bit more about that. You've shared a bit about that online, and I love hearing that we can do all of these great things for patients and still have at our core that servant leadership is a value. And I love that you talk about that. So if you don't mind sharing a little bit about that philosophy and how it guides you and why.
Yeah. So I think it first kind of became, or I guess I first learned about it at my first job. So I worked at a local retailer. I wrote about this recently, and thanks for letting me do that guest post.
Yeah.
So this was where it kind of came from initially. It's called Eagle Eye Outfitters, a local retail store, sells outdoor clothing and gear and stuff like that. It was very customer service heavy, like very focused on the customer, and that's where the phrase kind of see a need, meet a need came from. And it was about like whatever the person in front of you needed, anticipating that need and meeting that need, whether that meant getting them particular item that they needed, speaking to them first and just being kind and, improving their day by sharing a nice word or a nice moment with them. Or if, say, it was a particular item we didn't have, we wanted to meet their need by guiding them to another store that would have it. And then further along, going to the University of Alabama and working with the softball team there, Coach Murphy and that whole program and culture really talks about servant leadership a lot as well. I can think of some different phrases, like probably one of the first things I heard him say was, the sooner you realize it's not all about you, the better off you'll be. And so kind of trying to think about that perspective there as a role of a student manager. My goal was to support the athletes as best I could for them to perform as best they could. So for me, that meant setting up practice as best I could, catching ground balls, fly balls, whatever, catching bullpens, all that sort of stuff, just to support them however I could to serve them to be the best they could be and reach the endeavors that they wanted to get to and help the team. And then just further in different reading I've done, I think Patrick Lencioni is one that talks about servant leadership and organizational culture. And then I said my faith background as well as seeing myself as a servant and how I treat people in front of me, whether that's patients or if that's y'all or whoever I come into contact with, and just wanting to serve others. And I think often from a leadership perspective, we can kind of think culturally more of like, I'm a leader, so you just have to do what I tell you to do, or I'm your boss, so do what I tell you to do. Whereas if the servant leader perspective, I think is one, let me kind of be an example and show you what I want you to do, demonstrate the behavior, but also how could you serve those who may be subordinates or colleagues or whatever the case is. That's kind of how I see that.
So that's perfect actually, and I think Simon Sinek has a lot of good writing on this exact topic. That the leader always eats last, right? Like your primary responsibility is to actually the well-being of others. So let's do a little time travel experiment, and in 10 or 15 years, you are a chairman or CEO of this large PT provider. You're responsible for 1,000 clinicians in your network, and you have a large contingent of younger clinicians that are entering your network. So if you have unlimited resources, what are the three things that you would want to give to your clinicians early in their career that can really help elevate their practice and help them thrive for the rest of their career?
And
Unlimited resources.
That's a daunting task. I didn't know I was that ambitious. I think first I would think about community, having people around those young clinicians. That's something I want. I think we are all drawn to community as humans in general. Having a small group of people. I wrote about recently my two close friends that we call the Junto after Benjamin Franklin's Mutual Improvement Club. And I think getting small groups like that and having a community where you can go and you can learn, you can talk about struggles, be vulnerable, iron sharpens iron and that sort of thing, be challenged but supported at the same time. So developing those close relationships, I would want to implement that in some way. I'm sure that would be difficult, but that was one thing I would think about. And then direct clinical mentorship, I think, is another huge piece of having like the wealth of knowledge that you are, Alex. If some young clinician had access to you and, you met on a regular basis, a regular rhythm to be able to run through different challenging cases or whatever the case is, just to have, someone like you or a mentor who's been there and done it to kind of guide you through the process. So that's two. So, those are the first two that came to me. Now I've got to think of the third. Yeah. I think the third, unlimited resources. I'm going to go back to tuition real quick. If I had unlimited resources, I think that would be a big aspect is to somehow be able to assist with that, because I think you're spot on with how challenging that rise in tuition is, and pay has been similar, about the same, and the financial strain and decisions you have to make based on that at times. So I think the first two would be community, clinical mentorship, and then some form of helping with tuition or financial monetary value.
If you look into the economic breakdown of cost return based on PT tuition, in the entire healthcare spectrum, physical therapists are the worst in terms of the price of tuition versus the salary for the first 5 years of practice. So if you do and this is an aggregate of the APTA data from just 2020. So I'm sure it's gotten worse in the last 5 years. But once we're done with the episode, we'll post a link to the APTA document about the risk of rising tuition, and then look into that national salary averages. It's not a mathematics that works, because an average clinician will be indebted for pretty much the entirety of their career unless we can figure out a way to either elevate the pay, which is absolutely important, but also reduce the cost of education to be manageable. Because I think you absolutely are serving an integral part of healthcare in the United States. But without the right financial incentives, it's very hard to keep clinicians doing what they're doing for the entirety of their career, right? And that is the challenge. We see that we have a 10 to 15% attrition of clinical staff early in their careers. These are clinicians that are leaving PT practice after less than 7 years in practice. Based on the three aspects that you just said, what's the best way to keep clinicians that are maybe struggling a little bit, are having difficulty, potentially because of this financial burden, and use that dichotomy of being unhappy with your job or being unhappy in your job? How do you find the right setting and the right fit where you both find happiness in your job, happiness with your job, and still maintain a financial viability?
Yeah, I think that's for sure a challenge. I think of the three things I mentioned, the community and clinical mentorship piece, I think are huge aspects of it. And especially if you have a young clinician who is craving to just get better regularly, having those people around you that you can be challenged with, supported by, walk through difficult times, because I think that becomes even more apparent when you have difficult times in your life, personal life, whether that, outside the clinic, and you need that. But the culture that you're a part of, and the clinic you decide to go to, I think we need to be really intentional about choosing that. But then again, there is the financial constraint. So just like when we're thinking about that from our patient's perspective and their financial constraints and socioeconomic factors that impact their decisions, that is the same for us. Yeah, I'm not sure.
Physical therapy world has always had a two-prong incentive system. You can either grow clinically or you can grow fashionably, entrepreneurially, right? So you can become an administrator or you can become a good clinician. And we never created a third path for growth, which the rest of the medical groups have. So you can be a physician that can grow academically, you can grow clinically, or you can grow administratively. You can become a physician administrator. And the third stage of growth is an absolute necessity, whether through mentorship, through entrepreneurship, through any form where you can actually, without even directly gaining financial incentives. So we definitely have to figure it out. And I think, unfortunately, Cody, it will be up to you and your generation of clinicians to really solve some of these problems, because Dana and I are kind of looking from things from above, thinking that we know things, but it is you who will have to settle this. And I think you're already doing a wonderful job figuring a lot of these things out. You're using technology to your advantage. You're building an internal network and you're building an external network. So you are using a health system to build a true value-based approach to care. You are acting as a primary care musculoskeletal clinician, but you have a physician network that helps you. So I think you're on the right path and the right track. And ideally, if we have listeners that are going to be paying attention to this, they'll emulate and they'll contact you and help you rise and gain leadership on this too. I'm optimistic that yourself and clinicians like yourself will be able to figure it out and will be able to build a thriving profession for us again.
You're a leader,
Thank
whether
you.
you like it or not.
Yes.
All right, well, we have to wrap it here. This has been fabulous. And of course, we will be asking you to join us for a part 2 when it's convenient for you. This has been really awesome. I don't know about you, Alex, but I feel very hopeful when I talk to therapists like Cody, hopeful for our profession and hopeful for the patient community, the American community, right? Like, thank God we have folks like you who are thinking the way you are. Therapists have a hard job. We have to be able to touch. We have to be able to listen. We have to be able to talk at the same time. We have to be able to document. We have to be able to communicate. It's a really exceptionally challenging profession. And seeing, therapists like you thinking about this, the way I think Alex and I would agree is really the right way to be thinking about the profession as a young in your career is awesome to see. Thank you.
Yeah, thank you for what you do, Cody. And I'm 100% optimistic that you will build a much better profession for the rest of clinicians.
Any
I
last
appreciate
words, Cody?
just appreciate the kind words, and thank y'all for having me on. I really enjoyed the conversation. But yeah, I would be happy to be back and look forward to continuing to see the content y'all put out.
Thanks for sticking around until the end. If you enjoyed this podcast, we would be honored if you would like and subscribe to it. And of course, we would always appreciate if you shared it with a friend who might enjoy it or benefit from it also. See you next time.